Have you ever left a doctor's appointment thinking, did they even hear me? Well, you're not imagining it. And it's not just your doctor's fault. The truth is, the healthcare system has changed in ways that make it almost impossible for women and physicians to win. And today, we're pulling back the curtain on why. I'm Georgie, and this is Fempower Health, where we bring truth to women's health so you can make informed choices and show up stronger in the system we've got. My guest today is Dr. Sharon Malone, a board-certified OBGYN who spent more than 30 years caring for women and is now one of the leading voices on midlife health and how we can rethink care for women. In this episode, we talk about what's really behind rushed appointments, why women so often feel dismissed, and how both doctors and patients can start rebuilding trust. It's honest, it's hopeful, and it's one of those conversations you'll want to share with a friend who's ever felt unseen in a doctor's office. So let's dive in. Dr. Malone, it is such a pleasure to have you here today. Welcome to Fempower Health.
Well, thank you for having me.
So many women, they say, I feel dismissed. I'd love to hear from your side because I've been doing this podcast for many, many years. And what's interesting is the topics that resonate the most now with my audience are chronic pelvic pain and menopause. It's clear why, right? We have this fragmented system. I think right now with menopause, a lot of it's all about hormone therapy, but it's really not. Menopause is actually midlife, and that comes with its own set of complications. So help us put the pieces together because people who are listening are the ones that are frustrated and need answers. So tell us about your side of this.
Well, there are two things. And I think that one thing is historically, this is not new news. Women's complaints have been ignored and dismissed for the entirety of the time that we have been in this conversation. Women have always been thought, oh, you complain or you're whining or this is hysterical or it's all in your head. All of these things that we have really not given the full weight of their complaints and have them addressed. Because as physicians, we're really good about solving discrete problems.
Okay.
Pain, I can't see pain. Menopause symptoms or whatever's going on that may be happening with you, depression, irritability, anxiety, things that we can't see and we don't have an immediate solution for, we tend to ignore because, there's a certain amount of hubris, with the medical profession, I should say. We like to say that we know the answers to things. And things that we don't have an answer for, we push them to the side. And that's why I think so many complaints have been ignored, not just because the complaints weren't legitimate, but sometimes the complaints take more than a 15-minute visit to sort out. Sometimes I've done all the things that I can do diagnostically, and I don't have an answer. So I don't want to talk about that anymore. That's sort of from the physicians, I'd say the historical perspective about why physicians are dismissive of women. There's also an additional pressure that's going on right now that wasn't really the case 30 years ago. There have been these real serious inflection points in sort of how we have practiced medicine in the 30 years that I've been here. When I started, we went from that old way of doing it to insurance-based. The insurance company is in charge of what medications you can get or what doctor you can see. That took away a bit of the autonomy of the doctors. And now what has, I think, further deteriorated that relationship is the fact that now doctors are no longer even in control of their time. The traditional private practice where it's a physician-owned practice is becoming a relic. Most doctors' practices now are either owned by corporate entities, either large hospital groups or insurance groups, or private equity groups are coming in and stitching together these practices. And unfortunately, it means that doctors are not, you don't have any autonomy. You are not only being told what you can and cannot do by insurance companies, you are told what you can and cannot do by your employer. You're told not only how many patients you're going to see a day, but how much you're going to get paid for seeing said patients. So there is no upside to being thorough. And that's unfortunate, but that's the reality. And to be honest with you, that's why I wrote my book, Grown Woman Talk, because before we got to all the medical issues, I really wanted to explain to patients how the system has changed and how your assumptions about the way it was, it's not that way anymore. And it's going to require a much larger buy-in on the part of the patients to know how to show up and how to be efficient. Because if you're only going to get a 15-minute or a 30-minute appointment, you can't waste time. You've got to come in there loaded for bear, knowing what your complaints are, having all your records in hand. This is sort of how I think it's deteriorated that doctor-patient relationship. It is understanding that if you go to one doctor or if you go to the emergency room and you have something done and tests, and you go and they say, okay, follow up with your doctor in 3 days. You say, okay, follow up in 3 days. And you get there and you say, well, didn't they send my
Right.
records? And I'm here to say, no, they
Right.
didn't. If you're not part of the same hospital system, your doctor has no more access to your records than if they were locked away in someone's office somewhere. And I think that's an assumption that people make, that we have access to everything, and we don't. All of these things sort of get in the way of really being able to get the care that you want. But I think that people are capable of adapting to the new system if you only knew what the new rules of engagement were.
Exactly. No, that's absolutely true. There's been a lot of discussion in the healthcare system and with payers around value-based care.
Mm-hmm.
And so just for the audience to explain, so what they're trying to look at is right now the concern is that the fee-for-service structure, because of all of these crazy things that have happened with businesses buying up practices and the way doctors are paid, because the structure is set up that it's fee for service, the way to generate money is to continue to do procedures and tests. And so they're trying to figure out a way to make it around value-based care. And it's interesting to hear from you that it feels like the decision making is out of your hands. But I can also see on the other side of trying to make it holistic. For example, if someone comes into your office with chronic pelvic pain, obviously you're going to have to be doing tests. And I can assure you that the coding system with the payers does not take into account chronic pelvic pain. And I'll give you a concrete example of incentives driving behavior. And again, first of all, I want to say, and I'm sure you will agree with me, doctors are not bad. Doctors want to help. The systems are not set up. So let's just start
Right.
there.
Right.
I've put together this endometriosis working group globally. We're trying to solve this problem with patients that suffer with endometriosis. And I know the issue is more broad chronic pelvic pain. But in the United States, there is a code for endometriosis surgery. It is one code. That's it. And there are two ways to do the surgery: ablation, which is 45 minutes, excision, which, depending on the patient, could take 10 hours. The doctor is probably going to be doing ablation, right? And add to that, there's only few excision specialists that truly know endometriosis. At least that's what the community has been discussing. And again, I don't think it's on purpose. It's not a plotted thing, but that is one of the concerns. So they've actually gone to Capitol Hill in the past couple of weeks trying to talk to them to say, we've got to change the coding. And it really should be like chronic pelvic pain. You have said patient, this is the fee, and these are the things that you can do. But if the coding isn't right for even a surgery, that's not going to help. So it's like this very complex puzzle piece. I'd love to get your thoughts on this.
Well, it is very complex. But here's the problem. Let's back it up a little bit even before we got to the coding issue. When you talk about the inequity of the payer system, as an OBGYN, obviously 100% of our patients are female. And now, increasingly, about 90% of the physicians taking care of the female patients are female. So you can do a procedure on a woman and you will get paid 30% less for the same procedure on a analogous portion of a man. So we get reimbursed less for all of the procedures that we do. We get paid, imagine for a delivery, and I'll give you an example here in the DC area, and it varies by the region. For the delivery of a baby, and people think that doctors are trying to do C-sections because they get paid more money. Trust me, it's not that. It is you get basically 8 months of care, how many ever hours you're in the hospital delivering a baby, and a 6-week visit or 2-week visit or however follow-up, countless phone calls. You may get reimbursed $3,000 or $4,000. Now, you can get there are doctors who get that much for taking a mole off in the office. So the value of taking care of women is not appropriately valued. They do not compensate, just as you're saying, if it's something that takes an hour or something that takes you 6 hours. And this falls disproportionately to fields, and I won't say that was what the intent, but this is what the effect is, to all fields that are predominantly female. Pediatrics, internal medicine, family practice, OBGYNs are undervalued.
Yes.
And I agree with what you're saying. No doctor goes to medical school because they think they're going to get rich. There are other things you can do if that's your main goal. They genuinely do have the intent that they want to be helpful and they want to do the right thing by patients. But let's be clear, doctors are no different from lawyers and business people. There are scrupulous ones and there are unscrupulous ones. They are the minority, but it has made the whole practice of medicine increasingly difficult. So now you can't have your own practice. You have to have someone run it for you. And they decide how you get paid. And these RVUs, or the relative value units, are going to decide how you get compensated. They are in a real financial squeeze, and it's making them, let's just say, a lot less happy on the job. I felt a completely different way 30 years ago. I mean, I loved what I did even when I left, but I had a lot more latitude.
When you were talking about the relative value units, I had learned about this at a reimbursement summit that I went to in March. And I'm assuming you're referring to the paper that Louise King and Jocelyn Fitzgerald had put
Yes.
together. And I
Yes.
heard the same thing, that there are even hospital systems, even some of the academic medical centers, they just structurally, it's almost like the whole field is getting pushed out to bring in the revenue generating fields like orthopedics, et cetera. And it's really also creating these OBGYN deserts. I mean, it's creating such a downfall. And this is why, so one of the things they had shared, so folks understand like how these pieces work together, is there are so many people trying to fix this, but because the issues are intensely complicated, you kind of have to put stakeholders together and join forces. So, for example, with the reimbursement summit, one of the things they're trying to do is talk to, I believe it's the AMA that decides who is on the committee that determines these relative value units. And one of the, if you look at the list, there is an OBGYN there. They said, can we just get one more seat at the table and perhaps have deeper experience in other areas, right? So that's one of the things they're now pitching to the government. And I don't know where that stands. And hopefully that will change some of the guidelines. And, what's interesting is pharma, whenever they come up with drug, or if there's a diagnostic that is new to the whole field, I will say, I know a lot of folks are not loving pharma, but we have to give them credit. They are the ones who educate the payers, the clinicians, and trying to change the system so that there can be reimbursements. It's not perfect because it's just for that thing. So each stakeholder, each company is solving like this tiny piece of the puzzle, which makes it tough for everyone.
And they're competing interests.
Exactly.
And it is, as I said, we're all competing for a finite pot. And to give you an idea, that most hospitals think of OBGYNs, they think of us, we're money losers
Yeah.
in the hospital. But they don't think of it from the standpoint of where you deliver your baby or where you have your surgery. Women are primarily the people who are the gatekeepers for their family. So where you have your baby is where you're going to take your grandmother when she breaks her hip, or where you're going to have your spouse or partner go and have their gallbladder taken out. Sort of, again, it's undervalued for the things that women do and the things that we have to have done for us. But here's the problem. I think that, when you say AMA, God bless them, but doctors have been so poorly represented when it comes to the lobbying efforts because you're up against, these large corporate interests. And to give you an idea of why we've not been able to really advocate for ourselves collectively, you would think, okay, AMA or whatever the professional organizations would be the obvious people to do that on our behalf. But to give you an idea, with private practice, now what we are told, just with insurers, the insurance companies basically, when you sign up to be a member of whatever their panel is, we used to own the patients, right? As I say, own the patients as physicians. No more. The patients belong to Blue Cross Blue Shield. They belong to United or Aetna, whoever it is. And then you petition them to say, oh, please, Mr. Insurance Man, can I see your patients, right? And they're like, okay, you can. But we're going to tell you how much you're going to get paid for that. In that negotiation, if I'm a practice and I'm a solo practitioner or there are 5 of us, and you tell me, okay, well, this is what I pay. And you say, that's ridiculous. That's not what I charge. Do you know what you have to say about that? Their answer to that is, well, take it or leave it, because we're going to find somebody else that will take it for that amount of money. So
Right.
It puts doctors in a very bad bargaining position. And the smaller you are as a practice, the less bargaining power you have.
Crazy.
However, and that's why I have to applaud Dr. Fitzgerald, because she is making these things known. It's really got to come from a groundswell. And I think if
100%.
people really understood.
There's 2 observations that I have, and I'm curious what your thoughts are. So one is I'm seeing a lot of the academic medical centers, and for those who are curious what those are, that's like the NYUs, the Mount Sinai's of the world, Johns Hopkins. Unfortunately, they're more on the perimeters of the United States. So they're trying to create women's health centers in hopes of solving for this fragmentation. The other thing I'm noticing is with menopause, because it's, as we discussed earlier, it's midlife, not let me prescribe hormone therapy. A lot of the clinicians are now cash pay because it is so complicated to treat these women and it needs to be holistic. I'd love your perspective on both of these observations.
There are 2 things. Care of women in midlife. First off, I think that we have a model for what we could do with care of women in midlife, which obviously is 40 plus. We could say, and we should say, and this is something that is actually afoot, is that it should be a separate specialty. Because OBGYNs, we're asked to do a lot of stuff. You have patients anywhere from 12 to 80. You've got to deliver babies, counsel about contraceptive. It is everything that is female related falls under the purview of OBGYNs. It's too much. The care of women in midlife is not a one and done. Even when you do hormone therapy, it's an iterative. I need to check in. I need to make sure. We need to make adjustments all along the way. And as we said, in this environment about how you get paid, it's not worth it.
It's right.
It's not worth it, which is why it doesn't get done. But let me tell you what happens to women in midlife. The doctors that are really good and know how to manage, and they are few who know how to manage women in midlife, Because it's not worth it in the insurance market, what do? They come out of it, and now you are a concierge doctor, or you are a fee for, you pay $1,000 to come in for a 45-minute or an hour consult. And so there's the rub. To do a really good and thorough job, you can't keep the lights on for what the
Yes,
insurance will pay for you. So you've got to carve that out and make that a separate specialty. And you've got to make sure that the compensation is commensurate with the work that you put into it, because it is more complicated than take a prescription, here's a prescription, go away.
exactly.
But here's the bigger issue is trying to understand what we can do to make the delivery of care more accessible and more efficient. Because even if you found this doctor, and let me say this, it's as much a problem in New York City as it is in Mobile, Alabama, in terms of finding someone who knows how to treat menopause. It's a problem. So what you've got to do is say, well, perhaps how we are delivering care is inefficient. And that is why a lot of what we do in medicine, and particularly when it comes to menopause, is going to be done in the digital health space.
Yes.
Because you have to, so much of it is education on the front end before you even get to discuss the options about, well, is hormone therapy right for me? What are the lifestyle things I need to do? On and on and on. That can be done so much more efficiently in the digital health space,
100%.
because guess what? You don't need to take a half a day off from work and pay for parking and wait for an hour and then get a 15-minute appointment and walk out and still not understand what you're supposed to do. Digital health is going to be a huge component of it. Artificial intelligence is going to be a huge component of all of our care moving forward, not just menopausal care. And that's why when I left private practice, the one thing I realized is that I did give my patients the care that I would want to have myself, and the care that I would want my family members to have. But you know what? I paid a huge price for that, because that meant I could only see half as many patients in the course of a day. Let's reimagine that space. We have to do several things. We have to educate women. We have to show them what their options are. And to do that at an affordable, at a place where you don't have to spend $1,000. And that's where technology comes in. We can scale that and leverage the expertise of a few over 1,000, thousands of patients instead of 20 a day or 100 a week.
Right.
And that's really the place where we're going to land, somewhere in the middle, make it affordable. Now, is insurance ever going to pay for that? Probably not. What's the incentive? Who's going to make them?
This is something I want people to appreciate, even this digital health example. And by the way, I think there should be chronic pelvic pain centers, menopause, midlife centers, like anything that's complicated, we need a center. And my hypothesis is digital health can also help. Maybe digital health is the center, right?
Yes.
But there are ways to do this. Now I want to shift to the patient,
Mm-hmm.
because, I've been doing this a long time. And the thing that doctors have said to me over and over again is, we as the clinicians are experts on the conditions. Well, only the ones that we have enough research on, to be fair, and the diagnostics and the treatments. We don't have it for all the conditions. So that makes your job very, very hard. But the women know their body.
Yes.
And there's an observation that I have noticed is, how do women show up for themselves and how do women show up for their doctors?
Mm-hmm.
And it's interesting that women tend to wait, and we wait and we wait until we're suffering. And then we go to the doctor and we may be so fed up, we don't give the doctor enough information, and they haven't been with us for the months, days, years that we've been suffering. So they don't have the whole history. And we go in and we're like, why didn't you fix me? Fix me now. And it's a 10-minute appointment.
Mm-hmm.
So it's kind of like we need to show up for ourselves and go earlier. And we also need to describe what's happening and be an active participant and not assume the doctor has a magic wand. So I'd love to get your perspective on
Georgie,
this.
that is my book. It starts from how to pick a doctor. What are the questions you need to answer? And then, how the system has changed. So yes, there is something that patients have to do. But let me say this on the other side of this whole thing. For women, we have been socialized to accept suffering. It starts from the moment you get your period. You got cramps. Well, guess what? We can't see cramps. So here, take some Motrin. From periods to PMS, to postpartum depression, to migraines, to autoimmune, we accept it as normal. Urinary incontinence. I'm sitting there, I'm thinking, the solution is not, well, here, buy some more absorbent pads. But when you think that suffering is just sort of baked into the cake of womanhood, then you complain less.
Yep.
When you voice your concerns. And then those concerns, because they're difficult and they're going to take more than a 15-minute appointment, they get sort of minimized or pushed off to the side. Then there is this model of really what I call learned helplessness. You complain if you get a response. If you complain and you get nothing, then you just go, well, then what's the point? I just, I'll deal with it myself. That's sort of how women's health and complaints have been dealt with historically. And I always had a philosophy in my office. I said, one, it takes a little bit of humility. Because I would say to my patients when they would say, whatever their issue was at the time, and I would do all that I could do. And I would say, all right, well, we've done this. We've ruled out a lot of things. I still don't have an answer for you. I would say, well, you know what? Let's get a second opinion. I don't know everything. I don't have the answer to everything. Maybe there's something I'm missing. Because what I would tell my patients is this: you are the expert of you. I'm the expert in the theory. But if something is bothering you, don't let someone tell you, oh, it's nothing. You don't have to accept one doctor's opinion about whatever your condition is. So if you don't feel that it's been resolved in the course of that interaction and you feel as if your needs have not been addressed, then I say have a low bar for moving on, because that's what I want women to feel. I want them to feel empowered in this interaction. No, the doctor does not always know best. Maybe you do. And I've constantly been surprised by patients saying, no, this just doesn't feel right. Okay, well, then we're going to go figure it out. I will, to the best of my ability, exhaust all the possibilities before we get to it. And even sometimes you don't get an answer. That's the other thing. If we don't have a definitive answer, then let me figure out what I can do to make this better for you. Let's come up with a plan for how we're going to manage your symptoms. It should not be, well, then just go home and suck it up, take a Tylenol. That to me is just basic patient-centered care. Listening, believing, but that requires a little bit of time, the ability to interact with the patient that way. It also involves trust.
Yeah.
And that's what I said is more difficult in this environment, because being able to establish that is harder and harder. And I have to tell you, even in today's world, when I say AI is going to be a big part of it, because doctors don't know you and because they don't know your history, they're relying on AI. And I think that used correctly, though, AI is going to be a very powerful tool.
Absolutely. One thing I want people to appreciate again, which makes everyone's job hard, all the different stakeholders, is so I think a lot of people view women's health as the conditions that impact only women. But what I'm not sure if people fully realize is there's really also conditions that impact women differently, like heart attacks, and then disproportionately. So autoimmune disease, Alzheimer's, and the research that is done may not reflect the patient population. In addition, because we're so behind in research for many of these conditions, the doctors do not have diagnostics and treatments for all of these, which is why women are often hopping to doctors to try to figure out what they need to do.
It was hard to believe, but it was only until 1993 that it was mandated that women be included in clinical trials. was, even as of the writing of my book, when I had the latest figures were in 2022, $45 billion from NIH, largest funder of medical research in this country. Less than 11% of that went to conditions that either primarily or predominantly affect women. Less than 11%. Menopause was so low, they weren't even tracking it.
Right.
But that includes everything. Just as you said, autoimmune diseases, migraines, depression,
Mhm.
anxiety, all of these things. When we talk about things like cardiovascular disease and heart attacks, the language is even discriminatory. When women come in with heart attack symptoms, they go, well, she has atypical symptoms. Well, she has atypical symptoms because you're using the male model for what a heart attack looks like. You're not taking into account that women experience those things differently. We are very much influenced by the presence or absence of our hormones in terms of how we even react to medications. And, for time immemorial, we have the researchers. And see, this is the value of diversity. One, because having more representation in the researchers will determine what questions get asked. So that's important. Having diversity in the people who are reviewing those grants and research to say, if researchers aren't insane, they're not going to say, well, let me submit a proposal 100 times and I'm going to get rejected 100 times out of 100. They do the things that they get funded for. So people who are in charge of making this, that's why women's health has been undervalued and under-researched because no one thought it was interesting to know why two-thirds of the people with Alzheimer's are women. No one has bothered to really delve into why the health disparities when it comes to Black women in this country. We spend a lot of time talking about maternal mortality. Okay, yeah, that's true. It's the tip of the iceberg. Apply that to anything: heart attack, strokes, menopause symptoms, Alzheimer's, dementia, all of it. It's the same. You can use the same multiplier, but we keep acting as if we don't know what the answers are to some of these things. And some of them we kind of know,
Right.
but we sort of lack the political will to do something about it. Because it's not always the individual that's the problem, it's the environment
Yeah.
that people
It
are
is
in.
complicated.
Right, it's access to healthcare. Who has
Yeah.
it, who doesn't? So these are the kinds of things that I think as women, we have to stand up. There is the little a advocacy, which I say is the thing. How do you show up in a doctor's office and get what you need? But then there's also the big A advocacy. When you say we're 51% of the population, why do we get less than 11% of the budget on things that affect us? Why are we still scratching our heads about treatments for endometriosis? Why are we still scratching our heads about, wonder why women have so many fibroids? All of these kinds of things. We have been asking the same questions. Well, we haven't been asking the questions. We've just been looking at them and saying, women, that's what they do. What are you going to do? Yeah.
There are a lot of folks trying to work on making change, but what we need is participation, right? So there's one group, Women's Health Advocates, and they're working on, like, we're working on an endometriosis day on the Hill. They've done early detection breast cancer, and they do a lot of letter writing campaigns. So that's an easy one. So follow that group. We can take action. Another is when there are clinical trials, please consider participating. For endometriosis, one of the biggest struggles is patient enrollment. Without having patients to do any of these studies, it makes it really tough to get the treatments and the diagnostics to market. The last is, how do women show up? So I'd love for you to respond to that first part, but then I also want to ask you, what are the things that women would be surprised that you as a clinician need to know about them that they may never even think to share with you? We don't know how to show up.
See, Georgie, you could almost be a plant in the audience here. I mean, I spell this out explicitly, really, in my book. A big thing that women are unaware of because we don't talk about it is really family history. And not because your family history predestines you to any particular condition, one or the other, but it is helpful to know whether or not someone in your family has endometriosis, because endometriosis is more prevalent in family members. We don't know why or what the genetic basis is, but it does follow. Same thing with fibroids. Knowing what your family history is alerts me to the possibility. So many of us have never really spoken to our mothers, to our relatives. You need to know whether or not did my mother I'm here and I'm discussing infertility. Did my mother have problems getting pregnant? Did my mother have an early menopause? All of these things. So it starts with even knowing what the possibilities are in your family history. So know that. Anybody who has the opportunity to speak to, older siblings or whatever, because you'd be surprised. Someone says, "Oh yeah, I asked my mom about that and she had that too." And it really does sort of give us just a little signpost to say, well, maybe I should go down that road as opposed to the other 6 or 7 that it could be. We start there. And I think that coming in with a very clear history of your symptoms and knowing, and the one thing that I do say is know how to be a good storyteller. So much of what we do in medicine is just pattern recognition. I understand that if you can come in and tell a really cogent story and the timeline and everything about it, that's a huge help to your doctor in terms of helping you sort of come to a diagnosis or at least a differential diagnosis of the possibilities rather than looking at the entire universe of things that it could possibly be. So I would say those are the two main things. Know your family history, know what you could possibly be at risk for, and again, know how to cogently tell your story because that really helps.
Yeah, no, absolutely. We've talked about so many aspects of the healthcare system. It's great to have these short snippets on social media, and I think they're so helpful. But I don't know if people fully understood why it can be so hard. And so I hope people appreciate this discussion to just have that context.
Mhm.
And you've given, great insights on we actually do have some power within this system. Now, let's conclude. If you can wave your magic wand, what would you love to see? Different, better?
This is going to sound really Pollyanna-ish, but if I could wave a magic wand, I would, access to healthcare is so vitally important, and to me, it is so wasteful in this country that we spend as much money as we do on healthcare. And yet we have such poor outcomes that there are people who live in different parts of this country who have access to different things. So, I would address the disparities in access really and affordability because, when it comes to OBGYN, and it was difficult to find out that 50% of the counties in the United States do not have a practicing OBGYN. And that number is gonna get worse. So we have medical deserts throughout. So this is why I said, figure out our access problem. Figure out a way to make sure that every person who lives in this country deserves a minimum of health care, the basics, and it's not fair and it's not right that a few people get everything and, 75% of the people get either substandard or nothing. And so if I could wave my magic wand and I could say, what could I do? And then I would make sure that everyone had access to competent care and, understanding that we can't clone doctors. So that's not the answer. But, not being afraid to use the technology that we have available. And we're smart. We know how to do this. Everybody's got internet, don't they? You could have access. Should we have the technology and the expertise to make that happen and to get it to people who really need it.
I couldn't agree more. Well, Dr. Malone, this has been a true pleasure.
You are so welcome. Thank you for having me.
Thank you for joining me today on Fempower Health. If you'd like to continue the conversation, please follow me on social media. I am most active on Instagram, LinkedIn, as well as TikTok. You can also subscribe to the weekly newsletter if you want to stay off social media to get the latest and greatest updates. And you can find the link to that either on my website, fempower-health.com, which is a hub to all the different health topics I've covered over the past 5 years, or you can go to the show notes where there's links to all the helpful resources that are relevant to this discussion. And if you know of someone in your life who would benefit from this information, please do pass this along, because that is how we can ensure this important information reaches those who need it most. And for anything that is discussed medically, please understand that none of what we share on Fempower Health is medical advice. It is all for information purposes only, and only a conversation between you and your doctor can give you the care that you need. Thank you very much.